Okay. Hi, everyone. I'm Albert. I'm a medical oncologist from Jerusalem, from Hadassa Medical Center. I specialize in breast cancer and translational therapies, and we'll speak today about the personalized therapy approach in advanced, which means metastatic breast cancer. We'll speak a few words of introduction, then about the next generation sequencing, which is the major method that enables us to treat our patients better, and the specific findings that we can find them in metastatic patients that can help us to treat them better. These are the hallmarks, the 8 hallmarks of cancer. They were defined in the year 2000, and 2 more were added in 2011. These are the major processes that underlie the cancer. And if we want to fight cancer efficiently, we need to tackle these processes in order to stop them, and then we might be able to cure our patients. As you can see, all our treatment approaches are targeted against these processes: the sustained proliferation, the evasion of growth suppressant, avoiding immune system, the replicative immortality, the metastatic process, angiogenesis, avoiding of apoptosis, and the problem with energetics. Next. This nice illustration shows us our dream of personalized cancer therapy. We know, and previously, maybe 10 or 20 years ago, all the patients were the same, and we were giving the same drug to all the patients, helping some of them, but not helping others. And with the advancement, and we'll speak about it a bit later, with the molecular profiling, we see that every tumor and every patient are different. And our dream, and this is the future, and maybe even the past in some tumors and some specific scenarios, we know to select specific patients, for example, the yellow one, to take them out of the group and to treat them with specific drug. And the specific drug will help only the yellow patients. It will not help the red one or the green or the blue. So this is our vision, and the world of oncology is moving toward that approach. The molecular alterations are mostly at the DNA level. Why are we saying it's mostly on the DNA level? Because today we know how to look on the DNA. So we say mostly our DNA level. Probably in the future, we'll see more changes and more data about RNA and protein and more epigenetic changes. But today, we look under what we see under the tests that are available today. And today, the tests are best showing the DNA alterations. So we can see that when there is normal DNA, for example, the word beast, there can be different type of changes. There can be substitution, that specific letter is changed, and then the meaning is completely other. There can be insertion, a nucleotide or a whole amino acid or a large chromosome part can be inserted, also changing from beast to breast, for example. There can be a deletion. An area of the DNA can jump off and it becomes shorter, and again it changes the meaning. Or there can be inversion. There is a switch between the letters and beast become bits. All of these changes are in the DNA level, and they change the function of the proteins. They can delete or destroy the function of a protein, or they can make a protein to work without any control. Usually the oncogenes work, they lose the inhibition, so they work without control. This is the oncogenes. And the tumor suppressor genes, there's a defect with loss of function, so loss of their function can cause the cancer to appear. And what drives this whole revolution of the genetic data is the development of what's called next generation sequencing. In the year of 2000, there's a famous picture of President Clinton standing with the head of the NIH, the National Institute of Health. They are shaking hands and they say, yes, It is the year 2000, and we completed sequencing one person's genome. One person's genome sequencing cost in the year of 2000 was $100 million. $100 million. And as you can see, the green is what happened in the late 2000s. There came few companies that invented the next generation sequencing, which is faster, cheaper, and much better. As you can see, there's a steep decline in the price of DNA sequencing. So what was done in the year of 2000 in $100 million, in the years of 2019 is almost 1,000. So once it was only for the United States, the whole country invested in one person, but now almost every patient can do it. It's just $1,000. Next. So when we do next generation sequencing for the DNA of the tumor, we can find different alterations, mutations, fusions, deletions, inversions, as we saw in the previous slides. We can categorize them into three categories: benign change, variant of unknown significance, and pathogenic. The most easy is the benign change. It means that this change doesn't cause any change in the function of the protein. How do we know it's benign? There are several websites which everyone can use. You also can use them, Balsom or CleanVar. You can just Google it, and you write the specific change and tells you whether it's benign or not. Usually the benign changes are common and prevalent in the healthy population, and therefore we know it is benign. The pathogenic changes, for example, in tumor suppressor genes, such as BRCA1, if there is a change which is common in Ashkenazi women that cause breast cancer, we know that it's pathogenic because it was found in previous studies, or it was found in many people with cancer, so we know it's pathogenic. The new problem is with variants of unknown significance. What does it mean? If, for example, we know that the nucleotide in the 12th position, when it changes, it can cause cancer in some gene. But what happens when there is a change in the 11th nucleotide? We know that number 12 is oncogenic, but what's about number 11? So we don't know, and there is a lot of debate and controversy about this variants of unknown significance, and every year many of them become benign or pathogenic with the addition of new studies. But for today's talk, we know that every variant can be benign, can be variant of unknown significance, so we're stuck with it, or it can be pathogenic. Inside of the pathogenic changes, there are also two types. There is one which is called targetable or druggable or actionable, which means that there is a specific drug that can work on that change and block this protein. Unfortunately, many oncogenic changes are non-targetable. For example, the famous oncogene KRAS, it's super oncogene which is present in many tumor types, but currently, March 2020, it is non-targetable. We don't have any drug that can block it. But still, there are many developments. And in addition, one more term that we should know, that many of the mutations can be called driver mutations, but some can be called passenger mutations. And sometimes we see tumors with several mutations in several oncogenes. We know that on average there are 3, 4, 5 mutations, driver mutations. It means these mutations push the tumor forward. And if you will attack them and block them, the tumor will collapse. And sometimes when we have several oncogenic mutations, for example, we can have 3 pathogenic mutations, and all the 3 of them are actionable. One of them can be the driver mutation, and the others can be passengers, what means that the driver mutation actually pushes the tumor, and the others, it just by chance they happen. And then if we will block the passenger mutation, we will not affect on the tumor. So it's very important to block the driver mutation, but it can be very difficult to choose which mutation is the driver mutation. And sadly, the ugly truth, many people say that personalized treatment is the future, and we will take every cancer patient, we'll do next generation sequencing, NGS, and then we will treat him and he will go out and dance. But there are not many clinical trials well controlled with randomization that showed that this approach is reasonable, feasible, economical, and even it shows some efficacy. There are a lot of case reports, very nice, that patients got the drug and now they are happy, but there is no large clinical trial that showed that giving personalized therapy instead of chemotherapy will be better. And one nice example is 2015 trial from France that they took patients and randomized them into molecularly targeted agents according to the specific NGS that they did, and if there was a change, the patient received specific drug to their targetable or actionable mutations, and the other half of the patients were randomized to any chemotherapy that the doctor wanted. And as you can see here, this is progression-free survival, this is a year of follow-up, and the blue is the targeted approach, the red is the good old chemotherapy, and we see that there was no any benefit to the molecularly targeted agents and no benefit to treating according to the NGS. So until we'll have big and large trials for the general population of cancer patients, many physicians and researchers are still skeptical about this approach, but every year we're getting closer and closer to find the specific populations that we will be able to help them with a targeted approach. And how do we find this mutation? There are two options. One is to analyze tissue biopsy. Classical approach, we stuck a needle and we extract DNA from what we took out. And the second approach is the liquid biopsy. We know that tumor cells shed DNA into the blood. We can find DNA that is going by apoptosis, necrosis, or even active secretion. We can find in the bloodstream, not only in the blood, in the urine, stool, CSF, even in the sputum, maybe tears, sweat, I don't know what, you name it. We can find circulating tumor DNA. So if we can find circulating tumor DNA, we can analyze it, and therefore we don't need to stuck a needle into the tumor and to get the DNA from there. Today we know that this process is very complicated and there is a release of the DNA, it has some biological activity, there is a big controversy and debate about how it is cleared, but what we do know, and we know it from pregnant women, because today we can take circulating fetal DNA in order to avoid amniocentesis. So circulating DNA is already available tool in gynecology. And so in oncology, we can analyze circulating DNA. It's much less invasive than regular biopsy. And when we take DNA from the blood, we can get DNA that is shed from many metastases. So when we analyze it, maybe we can get a broader picture and to get the mutations that appear in many metastases. And when we do regular biopsy, we just stuck a needle into a specific lesion. So what we get in the sequencing is that specific lesion only. And so today the liquid biopsies, they're also becoming more and more available and cheaper, so we can use them to perform follow-up after patients. For example, if we have a patient and there is an increase in circulating tumor DNA, and then there is a surgery, boom, and it drops, we can follow after the patient, and if there is an increase, it clearly represents a relapse of the tumor. And if there is a relapse and we give effective therapy and the DNA disappears, we can know that the therapy works. And then if there is a molecular relapse, we call it, sometimes we can see circulating DNA even a year before we see the metastatic lesions in the CT scan or PET scan or whatever. So we can monitor therapy efficacy, we can find residual disease, and we can detect relapse with circulating DNA. And this is one of the approaches that will be most powerful in the next future. So what next generation sequencing, NGS, can add us in advanced breast cancer? So principally it can add two things. One is detect targetable germline mutations, and two is to detect targetable resistant mutations, which are usually somatic mutations in the tumor. And as you can see, I will speak only about targetable mutation because it will help us to choose the best therapy for patients. And very important paper that came out about a year and a half ago, researchers from the UK, they took almost 700 ER/PR positive, HER2 negative tumors, and they sequenced them at the beginning and after failure of hormonal therapy with aromatase inhibitors. And then they wanted to look what are the resistance mechanisms to aromatase inhibitors. So interestingly, they found that 60% is unknown, but large percent of women have resistance by targetable alterations. For example, almost 18% of women had alteration in the estrogen receptor 1, which we know we can target with fulvestrant, and 13% of women had mutations in the MAPK pathway, which is EGFR, RAF, RAS, ERK, MEK, ERK, and others, and some of them are targetable proteins, and these transcription factors and unknown is still for future research. And in addition, we can see that some of the mutations sometimes are present before, so the hormonal therapy does selection and kills all the blue, the sensitive cells, and then we have endocrine resistant tumors, and endocrine resistant tumors, sometimes we can do more for them because we can find the mutation that did this resistance and to address it. This is a very nice example of the SOLAR-1 study. This is a study that was published in May 2019 in the New England Journal of Medicine. It took women with ER-positive metastatic breast cancer that had disease progression on aromatase inhibitors, and they looked for PIK3CA mutation. And patients were randomized to receive alpelisib, which is also called Piqray, and or just fulvestrant with placebo. And as we can see, the PFS was the progression-free survival in the alpelisib treated group was almost doubled in comparison to women that were treated with the placebo with fulvestrant. And this is in small, this is a cohort with women that had PIK3CA, that had tumors with no PIK3CA mutation. And as we can see, the addition of the new inhibitor didn't affect them. So what the big news here? First, we have a new target for therapy. And second, we know that for metastatic breast cancer, we prefer to treat with biological and hormonal therapies before we get into the chemotherapy. So here we have an additional biological therapy for about 30–40% of the women that can postpone time to chemotherapy and can add additional, 11 months in median to women with metastatic breast cancer that they can avoid chemotherapy and prolong their life even longer. Another interesting target, as I mentioned before, the MAPK pathway. The MAPK pathway, so the EGFR HER2 is one of the players in that pathway. So also in 2018, a drug called neratinib also was, which is an inhibitor of the HER1, which is the EGFR, the HER2 and the HER4. As you can see here, patients with advanced breast cancer after many treatment lines where they did NGS, and women that had mutations in HER2 and HER3, were given neratinib. I'm talking about mutations, not the regular HER2 positive, what we call HER2 positive tumors. These are amplified. It's something else. I'm talking about mutation in HER2 and HER3. Most of the tumors here are ER positive, HER2 negative. But the HER2 or HER3 mutation is the mechanism of resistance. As we can see here, every line is a patient. More than half the patient had significant reduction of their tumors, and as we can see, 4 patients even reached complete response with an inhibitor that is taken daily, once a day, with excellent toxicity profile. So this is another example of how NGS can find a targetable mutation that can be relatively easy targeted with excellent results. Another target is the BRCA. This is not a new study, it's almost 3 years, that was shown that patients with ER-positive tumors or triple-negative tumors that were found with germline BRCA mutation, but again, when we do NGS to the tumor, we find somatic and germline mutations. They are there also. So in this interesting trial, patients with metastatic breast cancer after progression on hormonal therapies, but less than 2 lines of chemo, were randomized into olaparib arm, only olaparib tablet that is taken daily and with good, even excellent toxicity profile, and against any chemotherapy of physician choice. And what were the results? The results also were nice, not super impressive, but nice. There is a much better progression-free survival advantage for patients that were treated again with olaparib. So what is the added value? As we can see, we add to these women with metastatic breast cancer, we add them many months of good quality of life without getting chemotherapy. It's a good aim. In this study, there was no improvement in overall survival, but still the progression-free survival was significant enough. Moving forward, this is a very important paper published 7 years ago by Ludmil Alexandrov. He works now in the States. And he took all tumor types, as you can see, melanoma, lung cancer, colorectal, cervix, and all the others. He took all tumor types. And here on the y-axis, it's the tumor mutational burden, as we call it. The number of mutations per 1 million bases, per megabase. Tumor mutational burden, TMB. And as we can see, breast is relatively with low mutational burden, but some breast tumors have high mutational burden. And why is it important? Why? First, how we get this high tumor mutational burden. So the main 2 things that cause high mutational burden is mutations in genes that do DNA repair or involve DNA replication. The most common is mutation in the mismatch repair system, MMR. These are the genes that are correlated with the Lynch syndrome, HNPCC in that cause colorectal cancer, ovarian cancer, but still in small percentage, 3, 4, 5% of the metastatic breast cancers, we can find mutation in these genes. What this system does, the mismatch repair system, in normal person, when there is a mismatch of nucleotides, it fixes it and it switches to the right nucleotide combination. But when there is a defect in this system, we call it MMRD, MMR deficiency, and also microsatellite unstable tumor. There are areas that are called microsatellites that they become shorter or longer. Therefore, it's called unstable. When the mismatch repair mechanism is not working, many new mutations appear. Oh, sorry. Sorry, I pressed the wrong button here. When there is a defect in the mismatch repair mechanism, many nucleotide errors are appearing in the DNA, and many new mutations cause defect in the DNA. We call it MMR deficiency or microsatellite instability. Microsatellites are areas that when there is a defect in the MMR, these areas become shorter or longer or shorter, and where they become longer or shorter, it's called instability. So practically it's the same, MMRD or MSI high. Another mechanism, it's POL-E mutations. POL-E is a gene, it's DNA polymerase, but when there is a mutation in it, it replicates the DNA, but it puts many errors doing its work. So when there are many errors in the replication process, the mutational burden goes up. And the mutational burden, which is measured as TMB, tumor mutational burden, the number of mutations per million base pairs is going up. And why is it good that it goes up? This is our next slide. It's good when it goes up, because when the tumor mutational burden is high, the more the tumor mutational burden, the more response to anti-PD or PD-L1 therapy. Immunotherapy works better in high tumor mutational burden. Why is that? There is a theory that's called neoantigen theory, and that theory says that when there are a lot of new mutations, there are a lot new proteins and new protein structures, and where there are many proteins in the HLA on the cell presents to the immune system many new targets. And as you have more targets, new targets to the immune system, the more chance that the immune system will attack that tumor. And as you can see here, the tumors that were the most right in Alexandrov here, melanoma and lung cancer and bladder, these are the tumors that are getting treatment with anti-PD-1 with the greatest success. Melanoma, lung cancer, and bladder cancer. This is the first FDA-approved indications for immunotherapy. For example, here for colorectal cancer, this is the regular cancer, and this is the Lynch syndrome-associated cancer, which have enormous mutational burden and have the greatest success of immunotherapy. How it can be done cheaper without NGS? Many of the NGS panels have these genes of Lynch syndrome and POL-E and others, but it can be done very easily. And for example, in our center, every colon cancer and every endometrial cancer automatically are getting stained for 4 proteins of the MMR system. And as you can see here, this is a positive stain and this is a negative stain. And a pathologist can say easily when there is a positive and when there is a negative stain. And patients that have deficiency in MMR proteins, it's like winning the lottery because they have an excellent chance to get response to immune therapy. And even patients with heavily metastatic disease and many metastases can achieve complete response for many years. And interesting note is that we know that all the terms that I use now interchangeably, that MMR is like MSI, is like high PD-L1, is like high tumor mutational burden. It's not exactly the same, it's more complicated. This is a nice paper that compared all of these things and that showed that many have high PD-L1, some have high tumor mutational burden, some have both, and the patient that has many of them will have more chances to respond to PD-1, but still it is still exploratory. And for the individual patient, when there is high MSI high or MMR deficiency, it has high chances of responding to anti-PD-1, PD-L1. And for the patients that have high PD or PD-L1, they have also a better chance to respond to immunotherapy, but for ER-positive patients, it doesn't really target, more for triple-negative, but for ER-positive patients, MSI and MMR are much more predictive than PD-L1. And the last star of of 2019 is NTRK fusion. NTRK fusion is a receptor that is responsible for growth of neurons and is a new star because it was found that in some tumor types, as you can see, in many tumor types, but it's very, very rare in these tumor types, around 1% or even 0.5%, except the secretory breast carcinoma. When it's more than 90%, this NTRK gene does a fusion. It fuses with another partner. There are many partners, and then becomes a fusion protein that is very oncogenic. And it's very, very rare in all tumor types, but it's more than 90% in the secretory breast cancer. And there are several inhibitors, as you can see here. This is a trial that they took many tumor types. The purple is breast. And these patients were given entrectinib, one of the inhibitors of the NRTK. And why it is so, as I said, the rising star, because as you can see, this is tumor growth, this is tumor shrinkage, and as you can see, almost all patients that got this inhibitor, their tumor shrunk, including complete responses. For example, these two patients with metastatic breast cancer, complete response, and these complete responses, they're long-lasting. It can have a year, 2, 3, and for a metastatic breast cancer patients to be without any sign of disease few years, this is an amazing success. Still, it's very nice, but it's very rare to find this mutation, but it's a promising approach. So I would like to conclude this webinar and to say that next generation sequencing may add very critical and important information to patients with metastatic breast cancers. Sadly, it affects a small number of patients that actually can benefit from that. And there are several reasons. First is that there is a limited number of targets, of targetable targets that we can deal with them today. There is what we call financial toxicity. Many of the drugs, they are very, very expensive and it's sometimes unreachable, and it's true and problem worldwide. The second is drug access. Sometimes drugs, they're in clinical trials, so they are not accessible to the public. And another thing is that many, many times the NGS is done very, very late when the patient had 12 or 15 treatment lines. It has a very poor condition, very low performance status. And as we know in chemotherapy, when we take patient with the ECOG 4 or Tarnowski of 20, no matter what we will give him, he will not respond. So maybe we should do the NGS earlier. And of course, further research is clearly needed, but clearly this is the future of personalized and molecular oncology. Thank you very much. And so this is the time for questions now. We have a question. I will repeat for everyone. Can NGS influence, I guess, radiotherapy choice? Yes. There are mutations. Usually, it's germline mutations in DNA repair genes, such as ATM, RAD50, RAD51, and P53, for example. So patients with P53, ATM, RAD50, RAD51, all of these genes work as a complex, and they fix DNA damage. So for these patients, we try not to radiate them. We try not to give radiotherapy for patients with these mutations, because there is a high chance of secondary malignancy for these patients. They cannot fix the DNA damage, and there is a high chance of secondary malignancy in these patients. So there is an effect for, it's mainly germline mutations that affect the avoidance of radiotherapy. For example, women with young onset breast cancer in young age, that we do germline panel and we find, for example, ATM, we ask them and we refer them to mastectomy and not lumpectomy with the adjuvant radiotherapy. And I didn't have the second question is whether I saw NRTK positive breast cancer patient. No, we started about 6 months ago to do this test in our center for many patients, but still it is very rare to find these patients, so not yet. Have any more questions, so thank you very much, and I'll be happy to get your emails or whatever you would like. So goodbye and stay safe from the coronavirus.